Now, the topic is lasers and surgery for glaucoma, right? Good. So I'm in the right place. Well, why don't you sit a little closer where you can hear better? Why don't you, yeah, you can move up in the front there if you like.
I'll block your view. I'll block your view.
They might want to see you.
Block your view.
That's fine. You're not blocking anyone's view. You're okay there. You're fine. Thank you. No, block her if you want. Go right through here.
It'll make a better door than a window.
All righty. All right. So how many? So you've been here before, right?
Not to this lecture.
Not to this lecture, okay, but you've been to one of them, right? But you've been to none of them, right? Okay. So you're walking in at the 4th of 5 lectures. Okay? That's okay to walk in at the 4th of 5 lectures. So we've talked in the past about what glaucoma is and what it isn't, right? Then we talked about testing we do for glaucoma. And we spent a lot of time talking about how we treat glaucoma, what we do for it, what our intention is when we treat it. And then the last session we spoke about medications for glaucoma. And we went through all the types of medications we use for it. In fact, I'll give you, in that bag, is there a green sheet in that bag? Oh, you have it, good. That's the list of the medicines there. We sort of went over that in detail. And today we're going to speak about lasers and surgery for glaucoma. So let's do a little review for their benefit, okay? And for anybody else who's watching or whatever, okay? Okay. And we'll sort of put tonight's information in a perspective where it fits in with the other things we've talked about. All right, so when we talked about what glaucoma is, we talked about the fact that most people think glaucoma is pressure in the eye, but we decided by, I told you, but we actually, I explained to you the rationale why we really don't believe it's pressure is the disease itself, that pressure is really a risk factor for getting glaucoma. So in other words, if you have pressure, you're more likely to get glaucoma, but it's not necessarily true that you have to have one to have the other. Now, that's sort of surprising to a lot of people who are under care for glaucoma. And the reason for that is that once you figure out all the things that are associated and that may be causing glaucoma, when you get down to it, there's nothing you can do about the other things that seem to be related to it except lower the pressure. So once somebody is diagnosed with glaucoma and starts treatment for glaucoma, we spend years and years and years talking about the pressure. And that becomes a big focus. So much so that we start to even convince ourselves, probably the patients, but ourselves even, that the disease is the pressure. Even though in our minds as doctors, we forget to tell the patients that. We're not just treating the pressure, we're treating the disease, but we're using the pressure to try to control it. Only because we don't know what else to do. Okay? It's the only modifiable risk factor for glaucoma. Now we also talked about the fact that the glaucoma is, what it really is since it's not pressure, well, what is it? It's damage to the optic nerve which connects the eye to the brain.
What is HO?
We'll get to that. Well, I'll speak about that briefly. So the connection between the eye and the brain is very important, because if you lose the connection in the eye, it seems blind. It seems blind. It is blind from a functional standpoint. And the connection between the eye and the brain doesn't sort of die all at once. It's not like you cut it. It dies very gradually over a period of time in a characteristic kind of a way, which we call glaucoma. So that's what glaucoma is. It's death of the optic nerve that connects the eye to the brain. And since pressure is the only thing we can do to change it, to stop it or slow it down, we lower the pressure a considerable amount from wherever it started. So if it was very high, we lower it to a more reasonable level. If it was normal to start with, which happens a lot, then we lower it to subnormal, below normal pressures. And that seems to stop it. Okay? So that's what glaucoma is and what glaucoma isn't, so to speak. And then we talked about the different tests we do. One of the things we do is we photograph the optic nerve so we can monitor the disease. We photograph it. We draw it. We look at the visual field test that's done, which is a representation of the field of vision. In other words, when you look at me, you can see all around the room at the same time. When you lose your vision from glaucoma, you lose the side vision in the earlier stages of the disease, usually before the center vision's lost. So we measure the amount of visual field loss on a machine where you put your head in a bowl, you push a button when you see the lights. So that's another thing. We look in the angle of the eye. The angle is an obscure part of the anatomy of the front of the eye that helps us know what type of glaucoma somebody may have or is suspicious for. And we look at these things periodically. And we measure the pressure, which is what we're trying to lower. And then we talked about next about how we lower it. And what we do usually first is treat it with medications. And we went over a list of medicines and talked about the side effects, how they work, right? We talked about how they work, the different ways you can lower the pressure by making the eye make less fluid or have the fluid get out through the natural drain faster. Either way would lower the pressure. It's sort of a closed system, and you pump either less in or suck more out faster, and the pressure goes down. Makes sense. Simple. Plumbing. Now tonight we're going to talk about a different kind of plumbing. Okay? We're going to talk about what we do when medical therapy fails or is inadequate to control the disease. Okay? And that's what our task is tonight, is to talk about the different things we do after medicines don't work. We'll talk about the different kinds of lasers that there are. Now that's a very big topic in itself because there's many different types of lasers being used for many different purposes in all of medicine. And the common thing I hear from patients is, he had laser surgery. People come to me and say, I want the laser. Well, what laser? Well, the laser. They don't know that there's many different types of lasers and many different diseases we treat it with. Treat with it. Or them. It's more like it. So what we'll need to do a little bit when we talk about laser surgery is talk about the different kinds of lasers, and then we'll talk about the different procedures that we do, and we'll talk about some of the ones that are done for other kinds of ophthalmology or eye diseases so we don't get them confused. So when your friends talk to you about they had laser, you'll know a little more about it, and you'll be able to say, well, what kind? Was it for this or for that? And then after that, we'll talk about surgery and how it's done, a little bit about the risks of doing it and complications and problems we get into with it. And then we'll have time for some questions at that point, okay? But do you have any questions in a review mode? Any of you? That was a quick summary. I have a handout for you. You came late. Let me get you one. You've been here before, right? Oh, you have? Oh, good. I'll give you some other information, too. Okay. All right, so let's talk about lasers. We'll save the surgery for later. Let's just talk about lasers. What is a laser? Anybody have an idea what a laser is? A beam of light. That's good. That's a simple way of looking at it. The word laser actually has a meaning. The word laser, L-A-S-E-R, is really a word that comes from a lot of other words. It means light, amplification, stimulated by emitted radiation. That's what it really means, but nobody says it that way. But that's just because lasers work by, there's certain things about laser light that makes it unique. Laser light is different than a light bulb. You know, if you turn on a light bulb in a room, the light spreads out in all different directions from it, right? So that the further away from the light bulb you are, it rapidly gets less bright. Now a laser is different than that. You can shoot a laser at the moon, and when it hits the moon, it might only hit a square mile on the moon. You know, at a very large distance. Now, if you light up a light bulb on the Earth, it isn't going to light up very much of the moon. You know what I'm saying? So it spreads, it stays very narrow and collimated, as we call it, and keeps its energy in a very small space. A very concentrated form of light energy. Yes, light energy, very concentrated. And another thing about it is it's usually one wavelength. It's not a mixture of wavelengths, so it has a pure color. It'll be green or red. It might be invisible. It might be in the infrared spectrum where you can't see it, but it's a laser beam. It makes we'd wonder, how do we aim a laser that we can't see the beam of? Interesting. So there's different basic types of lasers, and there's, to make it simple for you, there's heat lasers that they have their effect by heating up the tissues. And then there's another type of laser which I would call more disruptive. That's a tough word. And but I can describe it for you, it'll make sense. The heat lasers are sort of like, when you were younger, probably most of you took a leaf and a magnifying glass and focused it on it, and the leaf you could get it to light on fire. Like a magnifying glass with the sun, you can heat it up and focus all the light. That's a heat effect. And that's what we do with heat lasers. We actually burn tissue by focusing the light and making it powerful enough. We heat it up enough that it burns it and has a thermal effect, heat effect. Some people call them thermal lasers. Same thing. These types of lasers are generally, in ophthalmology, they're argon, krypton. Now, if any of you are chemists, you'll know these are elements, and they're in a gas state in a gas tube. Argon, krypton, and there's some of them that have a variable. You can change the color, but and there's a diode laser. These work by thermal effect. So if somebody had argon laser, they generally had a thermal application of the laser. The disruptive laser, the classic example of that is called the YAG laser. Anybody hear that word, the YAG laser? Now there's other types of disruptive lasers, but for ophthalmology purposes, the YAG laser is the one you need to know about. Now these work differently. They don't heat up the tissues. They work by focusing the light energy not only to make it more powerful, but they do it over a large amount of energy over a very short period of time. And it actually has a totally different effect. It doesn't burn the tissues. It creates a mini explosion in the eye, inside the tissues. So you actually can see it. It's like looks like a little bomb went off. You actually see light come from the spot where it hit. Like a little shock wave comes. And what it does is it disrupts tissue. And it acts to cut. It cuts tissue. And it doesn't even have to be absorbed by the tissue that it's in. You can imagine that leaf had to absorb that light energy, right? It had to absorb it to get hot. So this energy from this laser would work even if it didn't get hot. It's focused and it's delivered and it goes crackle. You hear like a little snap. And it would actually, if you hit a leaf, it wouldn't burn it. It would tear it, a little tear in it. It would rip it apart in one little tiny spot. It's very complicated, but it does it. How it does it is it's a high energy in a very small space in a very short period of time. And it causes a disruptive effect. When we use these lasers to cut membranes in the eye, commonly it'll be used to cut an after cataract membrane in somebody that's had cataract surgery. So when people say to you, oh, he had his cataract out by laser, well, you can't do that. You can't take a cataract out by laser. But after the cataract's out, almost everybody, after a few years, develops a membrane behind the implant. And that membrane gets cloudy. Now, if we had to use a thermal laser on this whitish membrane, it wouldn't work because it wouldn't absorb the energy. You know, white, if you know a little bit about physics, white reflects back every color it shined on, and that's why it looks white. Black would absorb every color. If it was a black membrane, it would be easy to burn it open. But clear membranes in the eye can't be affected by a thermal laser. So you have to use a disruptive laser. We use the YAG laser. Now, some of these are in the invisible range. The YAG laser is invisible, and the diode laser is invisible. You can't see it. So to focus, as I said to you before, how do we focus it? There's another laser built into the lasers that we use. It does get complicated. And it's built in just so we can focus the laser you can't see. We use a red aiming beam, because these lasers work in the infrared spectrum, and the closest color you can see to infrared is red. So they use a red aiming beam, and we focus that carefully, and then we fire the laser, and the other laser will hit at the same spot because of the way they set the machine up. Clever. They work together. They focus in the same location. So we use the aiming beam in order to focus the real beam that we can't see. So the common things that are done with some of these things, I'm going to talk a little bit about what we do with these lasers that are not related to glaucoma, so it'll clear up some misconceptions you may have. This YAG laser is what we talked about is for after cataract membranes. After cataract membranes. The laser, that procedure is called a capsulotomy. A laser capsulotomy. Now, these lasers that we use in glaucoma, interestingly, were really developed for retinal purposes by retina specialists. So the argon laser has been around for a long time, but it was really developed to be used for treating retinal disease, such as diabetic retinopathy. It still is used very widely for those purposes. So these lasers are often also used for retinal disease. I'm not going to write it down, but particularly diabetic retinopathy and for macular degeneration. You probably know somebody that has macular degeneration. They may have had laser. Often they'll use the argon laser, but because of the color, they will sometimes use krypton or one of those variable lasers I mentioned. But these are all thermal effects of these lasers. They're using it to burn tissue to close blood vessels, to burn them shut so they stop bleeding, or to destroy retinal tissue to stop a disease process. So they're used to they're destructive by their nature, by heating and burning. Well, around late 1970s, these lasers were in the eye hospitals where we were trained, and we were still taking our glaucoma patients to the operating room for certain procedures, particularly on the iris. Those of you who were here before, remember we talked about the difference between open and closed angle glaucoma and the fact that we would do a laser procedure to allow the drain to open. That was called an iridotomy. Well, that laser was sitting right there in the hallway, and we're sitting and thinking of taking our patient to the operating room, never thinking that maybe we could use that laser to do the same, make the same hole. Well, in the late 1970s, a few people experimented and found that if you focused it just right and used it enough shots, you could actually make the hole in the iris without having to go to the operating room. That was a wonderful breakthrough. So for us who were taking care of glaucoma patients, it was wonderful to have, we didn't have to go to the operating room. So these are also used for glaucoma. Let's see, how should we do this? We'll say heat. They're used to make they're used to make iridotomies. I-R-I-D-O-T-O-M-Y. Now, remember, I always like to take words and break them down so they make sense to you. Ira means like iris. Okay, that's the colored part of the eye. Otomy is a hole. So it's not doesn't mean much more than a hole in the iris, which is what we said. But it sounds like it's something spectacular when we say iridotomy, right? But it really is just a hole in the iris. That's what we're doing. Okay? And we have found, after this laser became available, that, hey, why don't we try the YAG laser? Because we could blast a hole in the iris just as well, and it works. And in fact, it works so well that most of us now do our iridotomies with the YAG laser, but it's just as acceptable to do it with a heat laser. So you can use the heat laser and the disruptive laser.
Which do you recommend?
Depends on the circumstances. Sometimes I do both. Because sometimes one works better than the other. He asked me, which do I recommend? I don't think one's necessarily better than the other. Now, if somebody's on blood thinners like Coumadin, we have a problem. Which laser do you think in your mind might make more sense to use if somebody has a blood clotting problem? Would make more sense to use the heat, somebody said, yes. Because why? Because it sears the... Right. So if somebody, to answer, you asked me before, would I recommend in a certain situation where somebody's on Coumadin, I would definitely opt to use the heat laser, because if you cut the blood vessels and it won't stop bleeding. Simple reason. Now, it always bleeds a little when you do this with the laser, but it usually stops quickly if they're not on blood thinners, and it's not a problem. So that's a big use, and we were very excited about this, not having to go to the operating room to do iridotomies, because I remember years ago we'd have so many patients who were at big risk of developing a glaucoma attack. We'd look at their eye and we'd say, oh my God, this eye looks like it's about to have an attack at any minute. But who would want to say to them, we're going to go to the operating room and make a hole in your eye and pull the iris tissue out and chop off a chunk of it? I mean, we really reserved the surgery for when people got in trouble. And nowadays, we tend to look at those same people and say, you know, you ought to come back next week and we'll do a laser procedure with almost no risk. And they have it done, and they never will experience trouble. Actually, in a sense, cure them of angle closure glaucoma before it occurs. Now, that's not the average patient with glaucoma. That's only about 10 or 15% of glaucoma patients. But still, we see a lot of people who have that tendency, and we offer them laser if it looks like they're going to get in trouble, or could, or if they have it in the family, and or they're worried about it. They can have something done rather than having to go to the operating room and to have a bigger risk. The nice thing about lasers is you don't make a hole in the eye, in the wall of the eye, so bacteria can't get in. So you can operate with inside the eye with a laser without making an incision. And it's you're taking advantage of the fact that the eye transmits light. So we can do a laser procedure in the very back of the eye without having to make an incision.
Is that because it stains that spot? It doesn't tear a hole all the way through the pad? It just...
Right, the laser will penetrate the tissues where it's not focused. It won't cut anything. It's where it's focused. That's right. So you can shoot it in the eye like any other light getting in, and you can operate in far reaches of the eye, which you never could imagine before. It's changed everything we do and the way we think about what we do.
You have to figure out the distance.
Yeah. No, it's these. Well, you were asking how do you focus it? You focus it with the aiming beams. Now the lasers, the heat lasers, also use the ones that are in the visible range, use the same laser that fires to aim, but it's very low power until you step on the pedal, and then it kicks the power up to make the actual burn. But you focus with the same laser beam that you fire with. Okay, so that's one of the laser procedures that we do, laser iridotomy, very common. The other one that you hear more about is when people say, I've had laser for glaucoma, they usually are talking about laser trabeculoplasty. I'll put that right here. Laser trabeculoplasty. Now, let's look at that word. How many of you remember, we talked about, you have to remember, this is obscure now, trabecular meshwork. We talked about that when we talked about the drain in the eye. Now, that's in that strange and anatomical part of the eye called the angle, which is up in the front of the eye. In fact, in your paperwork, you have a drawing of laser. Laser trabeculoplasty is one of the procedures that you have a little drawing for there. That means, trabeculo means the trabecular meshwork. Plasty means like plastic surgery. You're changing the trabecular meshwork. Another very descriptive word for what we do. So let me do a little anatomy lesson here so you'll understand how we do it. We talked about when you look at somebody's eye and you see the colored part of the eye, and that's their eyelids here. What you're really looking at is the iris through the clear dome of the cornea overlying it. You can't see the cornea, but there's a clear cover over it. Now, if you could put your finger under the clear dome, you'd be underwater in the eye, and then took a hard turn, there's a point where the cornea and the iris come together. But that goes all the way around the eye, all the way around the outside of the colored part of the eye. And that's where the drain is. That's where the trabecular meshwork is. And that drain is very important for fluid getting out of the eye. You can imagine, it's the drain. If it's being made, it's got to get out. And one of the things we talked about is that one of the problems with glaucoma is the drain doesn't work very well. So what we do with the laser, and it doesn't even make sense, is we burn the drain. Now, again around the late 1970s, a couple of doctors from Baltimore tried this procedure, and we were shocked because we knew that what you do when you want to make glaucoma in a monkey is you do the laser and you burn the drain. You just burn the heck out of it all the way around. And what happens is the drain scars up, pressure goes high, and now you have a case of glaucoma you can experiment with. Okay? So the idea of aiming a laser in the drain and burning it, we were horrified. That would just make it worse. But these fellows were bold enough to try this on a few patients who were going to have their eye removed for another reason, because they believed, and it was very innovative on their part, they believed it might have a beneficial effect, so let's try it. And it sure did. It had a big effect. It actually lowered the pressure about 30%.
How long does that last? Is it come back later?
Okay, I'll get to that. So that's good. You can tell you're right with me. If you're one step ahead. That's how I know everybody's listening when people start asking me the next question. So we aim a laser beam, but what we do is we burn it less severely than we burn the monkey's eyes. Obviously, you give a light treatment. And we find that if you do this, the pressure goes down, the drain begins to work better. Now you would say, how would that be? Well, there's different theories about how that might be, and truthfully, nobody really knows the answer. Well, there's one theory is that perhaps it burns it and it causes the tissues to shrink where you hit the laser, because you put it at intervals, like you put a laser spot here and a laser spot here, and you leave the in-between portions untreated. And maybe when you shrink it here, it stretches it open in between. Another theory is that it kills the cells that line the meshwork in those areas, and what regrows are new cells that function better, so that the active living tissue in there works better. Those are two different theories, and nobody's really sure why, but it works. So that procedure has become a real important part of taking care of people with glaucoma. Laser trabeculoplasty. It's not done with disruptive lasers. It's done only with the heat lasers, and it tends to work with all of these lasers that we talked about as heat lasers pretty well, pretty equally. The classic laser to do it with, though, is the argon laser. It was the one that was studied first. So how do we use this procedure? And I will get to your answer your question. You asked, how long does it last? But I'm not ready to get to that yet. So what we do here, we're treating a person with glaucoma. For one reason or another, they're not controlled on the drops. Maybe we've tried one drop, maybe added another drop. Maybe they can't remember to take them. Maybe they don't want to take them. Maybe they have an allergic reaction to them. Maybe they're on a drop from each of the categories of medicine. Maybe they're on 4 or 5 medicines already, and they're still not controlled. In that situation, you can, as an option, use the laser, burn the drain. If we do it in funny ways, sometimes we'll burn half of it and see if it works well enough and maybe save the other half for later. But when you do it, you may get a 30% drop in the pressure. And if you remember in an earlier talk, we talked about our goal for treating glaucoma is usually to lower it about 30% from where it started. So you might say to yourself, well, why not just do the laser and forget all the medicines? Right? If that's what you want and the laser can do it, why not just do that? Well, first of all, if I wanted to get rid of most of my patients, I'd just tell them all they need laser. And they'll head for the hills. People don't want to have things done to them so fast. They'd rather try a drop. Plus, it's become standard of care to try the drops first. It makes sense. It's reasonable. You know, it takes a little more guts. But there actually has been a study performed that showed us that using the laser as a first-line treatment is not a bad alternative. They actually did a study and compared lasers and treatment with medicines, and they found out that both groups did relatively well. There were some failure rates in both where they had to go, the ones who had laser needed medicine, and some that failed on medical therapy and needed laser. But overall, it's a good option to consider. Okay, so we use the laser as a next step when we want to get the pressure down. Now, how long does it last? It'll last, if it works, about 80% of the time it works. If it works, it'll last from 3 to 5 years.
How long?
3 to 5 years. And it can be repeated. Of course, if you've done half and saved the other half, and when I say do half, I mean you don't treat it all the way around. You treat maybe the bottom half, or the left half, or the right half. You know, you do your burns, and you save the other half for a few years from now, if you can get away with it.
Keep on the same area.
That's a repeat treatment, which is different than a phased or staged treatment, maybe years apart. Yes, you can. Now, we do that sometimes when the laser worked for a long time, or a good amount of time, and you want to try it again. Well, when you do it again, of course, you're taking a chance that it may end up like the monkey's eye. It could. You know, you do it again, it may go up. There's a greater chance it would actually make it go up. And it doesn't tend to work as well or for as long, but it is an option. And for somebody that can't have surgery for one reason or another, refuses to have surgery, it's something to, again, consider as a repeat treatment. But generally, we wouldn't do it unless it worked the first time pretty well and lasted long enough to make it a reasonable thing to do for the future. Okay? So when we talk about lasers, that's about all you need to know, really, from a patient's perspective about laser, at least for right now. Okay, we do use other lasers. Actually, let's talk about the surgeon. We'll go back and talk about a different kind of laser that works in a different way. Okay? Because I'm trying to take you through what we would normally do as a phased treatment. Okay, so medicine's failed. We tried the laser. Maybe it worked for a while. Maybe it didn't work at all. But now the person's still, the pressure's too high. The glaucoma's getting worse, and we need to do something more so they don't lose their sight. And we've tried the laser, so now we could consider surgery. So let's talk about surgery, and then we'll talk about, remind me to talk about the other kind of laser. I'm going to leave some room to put that back in. But if I cover it now, it'll confuse you because it's not part of the typical treatment sequence. Surgery. Now, I'm not to say that laser is not surgery of a type because you are burning and cutting tissue. We'll just call it cutting surgery. But that's a little confusing too because we said, look, I use that word, that disruptive laser cuts. So anybody that tells you laser is not surgery, that's not true. Laser is a form of surgery. But we're talking about surgery in the operating room with knives here. Okay? Now in your little packet there again, there's another little drawing of a trabeculectomy. That's the common surgery we do first. Now, that's the laser. Trabeculoplasty is the laser. The other sheet is the cutting surgery. Okay, again, what do these words mean? Ectomy is to remove. Trabec is the same trabec as here. Here we're burning it and we're molding it, so to speak. Here we're going to take a chunk of the meshwork out. Now what we're going to do when we do this surgery is we're going to make a new drain. We're giving up on the drain in the eye. We've tried treating it with medicines to make it work better. We've tried turning off the fluid flow so it didn't have to work as well. We've tried burning the drain to get it to work better. Come on, we're kicking it. It won't work well enough. So we give up on that drain. Not completely, because it's still going to be there and it may help a little. But we're going to make a hole in the eye. Okay, we're going to make a hole, another way out for fluid. A hole. That's basically what it is. But it's not just a hole that the fluid runs out and runs down your face. It doesn't really get out into the tears. Here's another eye. There's the lower lid. We'll lift up the upper lid enough to do this surgery, and that's what we do. We basically hold the lid up, move the eye down. We make a little hole here, very small, at the top of the colored part of the eye. In the wall of the eye now, right at where the cornea and the white of the eye come together. Remember, the cornea was clear. You couldn't really see it, but you can feel it if you touch it. It's the wall of the eye. And what happens is fluid comes out of that hole, and hello there. It forms a little pocket on the outside of the eye. Comes out through the hole into a little pocket on the tissue. The white of the eye has a coating of tissue on it. It's not just white of the eye. It's conjunctiva, it's called. And if you touch it, it moves around. But we make an incision, we open it up, we make a hole in there, and we stitch it back up so the fluid comes out into a pocket of tissue. It's like a little bubble on the eyeball. It's called a bleb. B-L-E-B. Now, the fluid that comes out of there doesn't run into your tears. It's absorbed into the blood vessels in the tissues on the outside of the eye. And it actually becomes a new drain. Okay? Now, there are other operations to do this. Older operations. But effectively, this is the most commonly performed. It's an older operation, but nothing has beaten it. All the new devices and things you may read about, still, and this year, this time, this works the best, especially if you've never had surgery before. Okay, so we have the fluid coming out into the pocket on the outside of the eye called the bleb. Now, we can get this to work pretty well, but sometimes people have tendencies to make scar tissue. Let's say you had one and it didn't work very well. What do we do now? Well, we started adding medicines to the surgery. We started painting on the tissue to stop the eye from healing up the hole. Sometimes people form a wall of scar tissue around the outside of this bleb, or they form scar tissue inside and close up the hole. You know, it would be a good thing if you got injured, you'd want the hole to heal, but you don't want this hole to heal. So some people tend to heal it up more than others, and what we do is we add drugs during the surgery. 5-FU was the first one to be tested. We used to give that by injection. Sometimes we paint it on the tissues as we're working, let it soak in and then wash it away. But the one that's become very popular also is mitomycin. Both of these drugs are cancer chemotherapy agents. They're given to people in the vein to kill tissues, especially cancers. So they interfere with the healing process, and they make the hole stay open better. So if you have somebody that you need it to work a little better than average, or if you need it to work when it's failed before, because you know that person heals too well, you use these medicines with the surgery. And in these situations, you paint them on. You can give 5-FU injections afterwards or on the outside of the eye for up to 2 weeks after the surgery. But the effect of this is to make the trabeculectomy work real well. Somebody has a question over here.
Why the hole at the top of the eye as opposed
Okay, why put the hole at the top? Well, when you let go of the eyelid comes down and covers it. That's one reason. And you don't tend to feel that bleb there. If you do it at the bottom, we find that there's a much higher rate of late infections.
just thinking
Now, I'm going to take advantage of your question. Well, gravity won't help in that situation, because the fluid fills the whole eyeball, and it's really pressure that forces it out. It's not gravity. Now, these blebs can get infected, and if there's an infection that gets, let's say you get a bad pink eye or conjunctivitis from bacteria, the bleb gets infected. The eye has now lost its natural defense of having a thick wall around it. You got a hole. So the infection can go in through the hole. And you can get an infection and very quickly lose the whole eye. It can happen. It's rare, but it never happens if somebody doesn't have a hole in the eye. This makes it more likely this could happen. So this is one of the long-term risks of having this kind of surgery. However, we don't do it on just anybody. We do it on people that have been through this. They have bad enough glaucoma to warrant these kinds of risks. Another thing that can happen is it can work too well. And then the pressure can go so low that the eye can't handle it and the vision can be affected adversely. So what we often have to do in those cases is go back in and sew up the hole. Sew it up. Doesn't sound like a very good thing for a person with contact lenses is absolutely right. Absolutely right. That increases the risk that somebody might have an infection afterward. Plus, if they wear a big contact lens that fits around there, it's going to not fit so good when you got that lumpy bleb there. So it's not always a perfect situation. Okay, so to keep moving with this, because we got more to cover yet, what do we do if this doesn't work? And let's say we did 2 of them and it doesn't work. Well, now we start talking about something called tubes. 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 They're called setons. Now, here's what you do here. Since to get the fluid if somebody heals up the hole, what you do is you put a tube in the eye. It goes right in the eye from the outside. And you connect it to a little device on the outside of the eye. Now, you don't see it because, remember, there's a tissue on the outside of the eye that covers it, and then the eyelid's over it. The tube is clear, so you don't see it from across the room. Nobody says, "What's that tube doing in your eye?" You really can't see it. It's tiny, smaller than I've made it. And it shunts the fluid out and distributes it up here, so you get your bleb, you get a bigger bleb up here, way up on the top of the eyeball. Now, this is known to help when people have blebs that fail, because you're sort of bypassing the hole. The hole stays open from the tube. You can scar it up by making a lot of scar tissue on the other end of the tube, but it's hard to do because the surface area of that is very big compared to the average bleb. I've drawn a little out of proportion. Actually, it's often as big as the colored part of the eye. So that's another thing that you can do, and this is what we often run into. I get a lot of people referred to me that have been on all the medicines. They've had laser. They've had 1, maybe 2 operations, maybe a cataract out. And they send them to me because maybe they need a tube. And we'll put a tube in. No, it's not a wick. You asked if this is a wick or a tube. This is a tube. This is a hollow tube. Okay, that wick procedure is very new. It's very investigational. There is something that was written up recently. What that wick procedure is a modification of trabeculectomy. They don't make the hole all the way through. They put this wick in, and it's very questionable as to whether that's going to work as well as trabeculectomy. It's got tough competition because it has to beat what's been working for years for us. And so far, what I've heard about it is it doesn't quite beat it. It might be someday as good as, but it's no better as far as we know yet. Except maybe there's a little lower risk in doing it. But you still get a bleb. It works by the same type of mechanism.
You say that, you say that the bleb with the tube is as big
Yeah.
as the iris?
Yes, the tube, the other end of the tube. Your question is is the bleb as big as the iris? Yeah, usually the plate that distributes the fluid is back up on top. It's usually almost as big as the colored part of the eye. You don't see it though because it's way above. It's sort of like almost up. It's behind your eye, sort of in a sense. No, you don't feel it. No, you don't feel the tube. Sometimes you can feel the blebs, though, because the eyelid, they sometimes get bigger. They sometimes keep the eyelid from rubbing against the cornea, which it needs to do to keep it moist. So you can feel like the eye's dry and uncomfortable because of it. There are some downsides to doing that. This is why we have to select our patients carefully. We don't tend to go to the operating room with people who have very early disease. Okay? We try not to unless their pressures are very high. The risks have to justify, I mean, the disease has to justify the risks of the surgery before you operate.
You said that, I'm trying to picture this, the bleb is as large as the iris, or the hole is as large as the iris?
You're asking me is how big the bleb. The bleb is usually small, like I've drawn it.
Yeah.
Okay,
Which is as
and
large as the iris?
the plate, the other end of the tube, is often as big as the iris. The other end of the tube. You're mixing them up. These are two different operations. First you do bleb, and then if you have to go back, you put a tube in.
Oh, when you put the tube in, the area into which it has to drain is as big as the
That's correct. In fact, you want it that way. You're asking me, is this, we call that the plate, P-L-A-T-E. The other end of the tube, the bleb forms over the plate, which we want to make as big as we can get, because this, it seems as though the effectiveness of the surgery is related to the square surface area of that plate. So if you can get a bigger plate, in fact, sometimes I put some in that have two plates on them. You put one here, and they have a little tube to connect them to one another, so the fluid goes up one, down the other, and you get two blebs. And that increases the chances of success if you need a very low pressure. Okay, so now you have a bad case. We'll go on, and what would we do if that didn't work? Or perhaps you can't do it for one reason or another. Or perhaps the eye's lost so much vision that it's not worth putting a big operation there, big tube in there, a big surgery, or an older person. There's another way. We then go back to a different type of laser. Now, you'll remember when we talked about how do you lower the pressure in the eye. We said there's two ways to do it. One is to get the eye, to get the fluid out faster. So we work on the drain. That was how one of the medicine classes worked. And that's what we've done with the glaucoma operation so far, is we've made better drains. We've made a new drain. We either make a bleb, or we put a tube in to let the fluid out, and we've made new drains on the plates of the blebs. I mean, new blebs on the plates of the tubes, right? It's a matter of making new drains. Now, well, there is another way of getting the eye to get the pressure down. That is to make the eye make less fluid. You can destroy the part of the eye that makes the fluid. That doesn't sound like a bad idea, does it? That would work, and it does. Well, where's the fluid made in the eye? The fluid is made in the eye in the ciliary body. I'll show it to you in cross-section. This is a little tough anatomy. If you don't understand this, don't think you won't understand the rest of it. I'm going to say you will. There's an eye looking out this way. There we go. There's the iris. This is the eye looking out at you here. This is the eye in cross-section. Let's take the eyeball and look at it like it's taken out of somebody's head, looking at you, okay? This is the same eye. There's the pupil right there in the middle of the iris. Now, like I said, it's hard to understand. The drain in the eye is up here, and the meshwork was up here. The ciliary body is right here. And again, behind the iris, and it goes all the way around again. So the ciliary body is really here. But it's hard to understand. It's back here. The fluid that's made, there's the lens. Fluid goes through the pupil and out the drain. We talked about that in an earlier talk. But what I'm trying to do is locate the ciliary body so you'll know where it is so we can burn it. We want to burn it or freeze it or ruin it. We want to destroy the drain. So what you got to do is do something to this part of the white of the eye that penetrates in and destroys the ciliary body. Now what we should do is, instead of just saying laser, we should talk about the word ciliodestructive. Now again, this sounds scary. Because lasers, any way you destroy the ciliary body works well. You can do it by laser and you can burn it. You can do it by freezing it. We call it cryosurgery. Cryo, that's cold. You can destroy, you ever had skin lesions burned off with the cold? It destroys it. You can cook it with an ultrasound device. But again, that's burning it. A lot of these things have fallen out of vogue because of the difficulties in doing them or problems we have with them. We've done a lot of cryo freezing in the past. But then the lasers came around, and we found that we could use certain lasers to get into the eye. But now you got a different situation. You're not aiming the laser through the clear cornea into the back of the eye like light passes. You're now treating the white of the eye. So you have to find a laser that will penetrate through the white of the eye to get to the tissue underneath it. And we can do that with a laser. You can use the YAG laser, but not like in a disruptive mode. You can turn that YAG laser into a thermal laser too. This is confusing. A thermal. In the thermal mode. And you can apply an external beam there. You can use a diode laser. We're burning it with a diode laser. And you can get a little handpiece that hooks up to the laser and put it right on the eyeball and burn with it right through there. You don't see it because it goes through the white of the eye. You might hear it go crackle as it burns the tissue underneath. Of course, you have to numb the eye because it would hurt if you did that without it. So you numb it with a needle so they don't feel it. But you burn it a number of times, or you freeze it a number of times, or you ultrasound it. Now that's really fallen out of vogue. About 10 years ago, a lot of this was very unpopular. To use an ultrasound device, it was very expensive, and it didn't work a whole lot better than some of the other things we had. So we're back to using the laser most of the time when we do it because you don't get as much pain. The problem with doing this whole class of treatments as a group is that you're doing a destructive thing to the eye. You're not making a little hole so fluid comes out. That doesn't tend to irritate the eye very much. It doesn't, because the eye's sort of, you're not burning, you're not destroying anything, you're just letting fluid come out through a hole. Here you're destroying a good amount of tissue and the eye gets very inflamed. And when it does, it often gets the retina involved. And you can lose vision in the macula. It's called macular edema. Cystoid macular edema. It's a particular kind of retinal complication that occurs frequently enough with this type of treatment as a group that we tend to try to avoid doing it unless the person already has bad central vision. Let's say somebody's got bad macular degeneration and doesn't have any center vision. And they come to us having had a couple of these operations, and we're thinking, should we put in a tube? Or maybe we should do a cilio or cyclodestructive. Cyclo and cilio both mean ciliary body. Destructive is self-explanatory. Or should we do one of these? And we say, well, let's see, if we do this, they might mess up their vision. Well, their vision's already messed up. This is nice because you can do it in the office and not have to go to the operating room. Putting a tube in is a relatively big operation. It takes, an hour, hour and a half, a lot of cutting, bleeding. It's a lot of work for everybody. And there's different kinds of complications that can occur with each of these. But when that happens, if the vision's bad, this becomes a very viable alternative. Now, there are some complications besides retinal that can occur with this. There's been a report that perhaps when you do this, somehow it sensitizes the eye to immunologically in a way where the other eye can develop inflammation and have problems. So that scared a lot of us into shying away from doing these for a while. Just a couple of case reports that brought it to our attention that maybe we better be careful with that modality. So we tend to really reserve it for after tubes. So when we get into this discussion of should we do this or should we do that as a doctor, we take all these factors into consideration. It gets very, very complicated. Now, I'm going to go back a little bit. Can you imagine when somebody comes to me and says, Doc, I had a friend that you did laser. I want you to do it on me. Well, boy, that's a wide open question. Is I want the laser. Well, what kind of laser? What are we doing with it? You know, you can see that it's not a simple thing. And it's going to get more and more complicated as we become more inventive. There's newer and newer lasers coming out that work by different modes that are safer. There's another laser that just came out for doing during cataract surgery where you can do a cilio or cyclodestructive laser procedure during a cataract operation. You're already in the eye. You put a probe in the eye during the surgery, snake it around under the iris, and you can see the ciliary body. And they say, since you don't have to burn through the white of the eye, that it's safer. Well, the manufacturer of the laser said so, but a lot of the doctors that tried it found it was just as dangerous and had just as many problems as some of these others. And you got to be careful. You know, the media is very powerful today. Somebody comes up with a new device, a company decides they're going to market it, and what do? They hire public relations people. Next thing you know, it's on the Associated Press and it's on TV as a new cure for glaucoma. The newest, greatest thing. And it's hardly been tried because of the power of the media. And in fact, the WIC that you were mentioning is really just getting past the investigational stage, and yet people came in by the droves with that article in the news magazine saying, I want this. Because it said it might replace medicines, and all these people they're sick of their medicines. I would like this rather than taking my medicine. Now, an unscrupulous doctor would probably do a lot of surgery that way. But that has yet to be proven as good as what we already have. So you have to be careful when you read new things. Who's behind it? What's their motive? Go talk to your doctor about it when you hear about new things. That was a lot of material. But that sort of puts a cap on everything we can do so that you can see where these things fit in. Now there's another thing. We have a couple more minutes before I'm going to take questions. We have another factor that we take into consideration. It's not just what is the pressure and what have you done that determines the next step. There's another much more humane aspect of what we do that you have to really honor, and that is the age of the patient. Somebody asked me about age, but this is a different way of looking at age. The age of the patient. How bad is the disease? How bad is it doing nothing more aggressive than we're doing? How long is that person going to live? How long will it take for them to go blind if we don't do anything more? Because we're very good at operating and doing the next thing, and sometimes making more trouble than the disease itself might cause. So, when somebody comes in, I don't care that they've had lasers and all the medicines. If their disease is in the early stages and their field looks good, the optic nerve still looks pretty good, their pressures aren't too unreasonable. Yeah, you could make a case for operating, but are the risks really worth it? Or maybe you should wait a little longer. So there's no answers to these questions. These are things that are being studied by large groups of patients to help us make decisions, but nothing in the world is going to substitute for sitting down with the patient, explaining it to them, and letting them choose what they want. Let them see what they think about it. I have a lot of people who have been recommended to have surgery, and when I see them, I say, you know, you really don't have a bad case. We should watch it for a while before we do surgery. And they're maybe 85 years old. They're not in great health. And I say, you know, you might have to live to be 110 to go blind with this thing. And they usually will laugh and say, I'll never live that long. I say, well, then you shouldn't be worried about it. That doesn't mean goodbye. You start to monitor it. You take your pictures of the optic nerve. You go back to the basics. You do the visual fields. You keep checking the pressure. Make sure it's not deteriorating more rapidly than you might have anticipated it would. And you can always jump in at a later date if it looks like your theory that they're not going to live long enough falls apart, or that the disease is going to be slow. So in other words, if the disease speeds up, they start living a long time. I mean, I've had people that I thought were never going to live another month. They come back to me having had open heart surgery, and it looks like they're going to go another 20 years. So you have to reevaluate where you're at. But these factors are very important, and they're often neglected. Often neglected. The patients want to know, what about that laser I heard about, that WIC procedure? It's like, hey, leave it alone. Just wait a little bit. That's a very important part of decision making, is understanding all this. We have a very hard time predicting how long it's going to take for somebody to lose their sight. And I wish we could tell that better, because that would guide us. When do we need to operate? When do we need to get aggressive? Be nice to know the answer to some of those questions. Would help us make decisions. Okay, that's the end of the formal part. We have a few minutes for questions, and if you have any, as usual, if you have any personal ones you want to ask me afterwards, we can do that too. Go ahead.
Taking in a lot of fluids, like recommended to drink 8 glasses of water per day, which is really necessary. Does that impact the person dying a lot?
Okay, so you're asking if people say we don't drink enough water, that everybody should drink 8 glasses of water a day. Right. Now, do you know that a few years ago we used to do a test called a water provocative test? This is a long time ago. Not too many doctors even know about it, let alone do it. We used to give people a quart of water to drink or so, and they used to take the pressure and see what would happen. And invariably, it would go up. And it was thought that if it went up more than a certain amount, that meant they had glaucoma. And if it didn't, well, they didn't have glaucoma. They were trying to separate out the suspects from the ones with the real disease. Well, eventually we found out it had nothing to do with it. But we learned that it makes everybody's pressure go up a little, but some people's pressures go up a lot. So that is relevant to your question because we know that it does make it go up. So the answer is, to that question is, yeah, you should drink 8 glasses of water a day, probably. Very few people really do. It won't hurt you to do it, but the point is don't drink it all at once. Don't drink it all at once. Drink it throughout the day, and it won't really hurt your pressure because once you get into the mode of drinking that much water, your eye will equalize. Its pressure will come back as long as you don't go drinking, a quart at a time. And even if you did it, it would only be a temporary thing, and it might not hurt that much. But it's a good question to ask if you have a issue with that. But
One glass at a time, you can wait.
maybe a tiny bit. But if you're going to drink 8 glasses of water a day, it wouldn't hurt to drink 8-ounce glasses of water. It won't raise it. You got to drink your water. Just don't drink it all. Just don't load the system all at once.
I hardly ever drink it.
Say that again.
I hardly ever drink
You hardly ever drink water. Yeah, a lot of people don't. Okay. You had a question, too.
After listening to this, you only talked about the pressure under the cornea, the iris of the cornea. It has nothing to do, there is no pressure that builds up inside the eye, behind the iris.
Okay, you're asking. Okay, here's your question. Your question is: we've talked about the pressure in certain parts of the eye. Okay, okay. So you want to know what's the difference between the pressure up here versus up here?
Call that the posterior chamber.
Yeah, there's a posterior and an anterior chamber, which is sort of beyond the scope of what I want everybody to know. But here's the point: the eye wall, the wall of the eye, is thick, relatively thick, and the pressure here is really, for your purposes, the same as the pressure here, anywhere in that closed system. Because the optic nerve is back here, and we do the surgery for glaucoma up here to let the fluid out, right? And that lowers the pressure back here and there. It equalizes. Now, where you're getting confused is that people say, with a certain type of glaucoma, that the pressure is higher back here in the posterior chamber than it is in the front. And that's why the iris moves forward. Well, the iris moves forward to equalize the pressure. So if you increase the pressure here compared to here, it'll push everything back temporarily until the pressure equalizes. So the pressure here and here and there are effectively the same.
So when you're measuring the pressure within the whole eye.
The whole eye, right. And you're also measuring the pressure on the optic nerve in the back of the eye.
But
So they go together.
pressure, because of the way you were describing it, and for the fluid to stay, as if it was only this front chamber of the eye.
So you're asking why was all our attention up here on the front of the
Is
eye?
that because you can measure it there easily?
Well, it's real hard to measure the back of the eye's pressure. That's true.
I mean, there is the cornea, the conjunctivitis, and also the eye. You don't only see the iris. You have the
Right. It's very hard to. The cornea is the only place that's easily used to check the pressure. So when you check the pressure here, we're working on the assumption that the pressure is the same throughout the rest of the eye. It equalizes itself. That's right.
The second question I had was on the laser beam. When it burns this hole, does it leave, usually when you have a burn, you have scar tissue there.
Okay. So what happens to the tissue that it burns? Well, yeah, what happens when you burn with a heat laser is it vaporizes some of the tissue. So you actually turn let me talk. In the center where the laser is applied, some of the tissue actually turns to gas. It's heated up very high. Some of it it shrinks and rolls up, and it does destroy the tissue. It doesn't get rid of all of it, and yes, there is scar tissue in there
Is that
around the edge of the hull,
or
and that would remain, and that won't affect anything. Sure.
That's what you call it, floaters?
No, floaters are something entirely different. Floaters are like my little dot, an opacity in the clear gel that fills the inside of the eye that normally lets the light through, so it casts a shadow on the retina that's perceived as a dark spot moving around. So that's not related to glaucoma directly at all. That's a retinal problem more. Okay, your question.
I've seen people way up in their 90s who never wore glasses in their life, and I just wondered if the eye aged same as the rest of the body, or slower, or what?
I mean, you're wondering why some people don't need glasses when they're 90?
No, it seemed like, I just wondered if the eye aged same as the rest of the body will age.
Oh, so in other words, you want to know if somebody doesn't wear glasses when they're 90, is it because their eyes don't age as fast? So their eyes are isolated from the aging process. Say that again? I can't hear you.
I just wondered if age had anything to do with, as you get older, your eyes would get worse, but there's a lot of people that don't.
I don't think we know the answer to your question, really. But, some people are lucky and don't need a lot of glasses. And as also, some people get older, they stop trying so hard to see. They're not so picky about what they do. And so they let their vision be a little blurrier. And then there's some people that just are lucky and rarely need glasses. Not too often when in the 90s do you see people that don't need glasses, though.
I'd
Yeah.
like to go back to the optic nerve. If there's anything preventive to keep that nerve healthy, like vitamins,
Yeah. You want to know if there's any way to protect the optic nerve. Yeah, well, not that we know of really hard facts that I can tell you to go take. But there's a lot of research being done now. It's very much in vogue to research neuroprotective, neuro meaning nerve, protective drugs. And there's a lot of work being done in that area right now. And I am very excited about that because it looks to me like if it was protective enough, maybe we wouldn't have to worry so much about what the pressure is. That would certainly change the whole way we treat the disease if we could make that nerve tough so it could handle higher pressure. But right now we don't know of anything that does that where I can say to you, oh yeah, go buy this or that. There isn't anything we know of, or we certainly would be telling you to do it.
I know with macular degeneration, they've been working with vitamins like vitamin A and zinc. And helping that.
Well, a lot of what's happened with the vitamins has been sort of shown not to be as effective as we had hoped. Not to say that vitamins don't help, we just can't find proof of that.
I did a little research in came up with 3 books, 20 minutes, with a lot of nutritional and herbal suggestions, vitamin C, omega-3 fatty
Yeah, there's a lot of books that have been written about that. Well, show me that later. I'll take a look at it later. Oh, okay, thank you. I'll look at it later. Okay, let's see. Well, we're about done. So if you have any other questions, let me know. Next week will be our last session. Will be the one where we'll be talking, the session on cataract surgery for the glaucoma patient. Okay, so that's, if you've come to these and you have glaucoma and don't have an issue with cataracts, you've sort of heard it. But cataract surgery for the glaucoma patient will address the particular concerns of people with both problems, which is very common here.
Do you always want glaucoma in both eyes, or do you just...
Ask me afterwards. So, okay, so thanks for being here. Okay. What was your question again?
Do you usually have glaucoma in both eyes, or just one at a time?
Usually it's both eyes.
See, I just went through something. I was with one doctor